Dear students, I am Dr.Jamil Abbas from the Physiology Department of the Faisalabad Medical University, and this is our third lecture, third part of the discussion regarding your thyroid gland. Today we are going to see the different abnormalities which are regarding your thyroid gland. A thyroid gland may become hyperthyroid or it may become hypothyroid. If it produces more thyroid hormones, we call it hyperthyroidism, and if it is going to produce less amount of the thyroxine, that is known as the hypothyroidism. Now, one of the very important thing is the goiter. Goiter means just an enlarged thyroid gland. It may be a hypo or hyper functioning. One of the other terminology uses toxic goiter. If a goiter is associated with a hyperthyroidism, that means the enlarged thyroid gland, and it is also producing more thyroxine, this is known as a toxic goiter. Another terminology which is known as the non-toxic goiter. That means goiter is there is enlarged thyroid, but it is not producing more and more thyroxine. So there is no thyroxine, or you can say normal amount of thyroxine is there, and the goiter is still there. This is known as the non-toxic goiter. But very important sentence is, but a diffuse goiter often evolves into a nodular goiter. Here you can see the shape of a very enlarged thyroid gland, which is known as the goiter. You can easily see, although this is a very enlarged goiter and it can easily be seen, but sometimes there is a very small enlargement in the thyroid gland. Now what is meant by let's see the hyperthyroidism. Why the thyroid gland begins to produce more thyroxine, more thyroid hormone? The two very common diseases are concerned. One of them is known as the Graves' disease. It's actually in the Graves' disease, the problem is an autoimmune. It is actually an autoimmune disease. An immunoglobulin, which is known as a thyroid stimulating immunoglobulin, is formed against the thyroid stimulating hormone receptors, TSH receptors, which are present on the thyroid gland. Actually, the TSH receptors are normally made for the TSH, but these thyroid stimulating immunoglobulins which are formed against these receptors, they begin to stimulate the thyroid stimulating hormone receptors, and thyroid has to produce a large amount of the thyroxine under the effect of these thyroid stimulating immunoglobulins. Actually, the thyroid stimulating immunoglobulins bind with the thyroid stimulating receptor and stimulate cyclic AMP system to produce more and more thyroxine for up to 12 hours, and thyroid hormone secretion may increase from 5 to 15 times than the normal. While the normal TSH can stimulate its receptor for only 1 hour, that means here is a huge difference. The immunoglobulins, they are stimulating the hormone for maybe up to the 12 hours, while the actual thyroid stimulating hormone stimulates its receptor just for 1 hour. So when there is a continuous stimulation of the thyroid stimulating hormone receptors on thyroid by the immunoglobulins, there is more and more production of the thyroxine, leading to a hyperthyroidism, and this process is known as the Graves' disease. Another very common thing is the thyroid adenoma. Actually, this is a localized tumor in the thyroid gland. It secretes thyroid hormone abundantly, but the secretion function or the secretory function of the rest of the thyroid gland is reduced due to the negative feedback of the thyroid hormone secretion. It means, let me explain the thing. Actually, the thyroid adenoma is a small nodular type of the tumor present in the thyroid gland. When this adenoma begins to secrete more and more thyroxine, the rest of the tissue the rest of the tissue production of the thyroxine is reduced due to the negative feedback effect on the thyroid stimulating hormone secretion. So thyroid adenoma and the Graves' disease, these are the two very common causes of the hyperthyroidism. Now what are the symptoms of the hyperthyroidism? One of the very important symptoms is the high rate of excitability. We have seen the functions of the thyroxine in the previous lecture. There is a high rate of excitability in the brain. Cerebration is there. There may be the anxiety. There may be the fine tremors, increased sweating, heat tolerance, weight loss. Weight loss is because of the increase in the metabolism. Mild diarrhea may be there. So all these things are the symptoms of the hyperthyroidism. Then a very important thing which is known as the exophthalmos. Exophthalmos means protrusion of the eyeball. Your eyeballs, they are protruded outward, and this is an autoimmune process leading to the edematous swelling of the retroorbital tissues and damage to the extraocular muscles. If it is severe, it may stretch the optic nerve. If exophthalmos, or you can say the protrusion of the eyeball, is so severe, it may stretch the optic nerve, and which may cause the difficulty in vision, or sometimes eyes cannot close properly. So the epithelial surface become dry and ulcerated. Exophthalmos is reduced when hyperthyroidism is reduced. Next slide is, here you can see the diagram of the exophthalmos. This is the exophthalmos. Then we move to the hypothyroidism. The hypothyroidism, that means the less amount of the thyroxine produced by the thyroid gland. And this may usually it is initiated by an autoimmune thyroiditis. That means again this is autoimmune process. There is inflammation of the thyroid gland. Ultimately there is a destruction of the thyroid gland instead of stimulation. It may be due to the dietary deficiency of the iodides, and which is known the endemic goiter. Normally we need only very small amount, that is 50 milligram per year of the iodine, but in some areas of the world like Swiss Alps, these are the mountains which are present in the Switzerland, and the Andes, and some places of the Andes, there are again the mountains which are present in the USA, and in some areas of USA even this minute quantity is not present. So no iodine, no thyroxine. This will lead to the more thyroid stimulating hormone, and ultimately it will develop the goiter. Then idiopathic non-toxic colloid goiter. Actually we don't know the exact cause of this one. Then if there is a surgical removal of the thyroid gland, it may produce hypothyroidism later on. Or there may be the destruction of thyroid gland by the irradiation. All these things may lead to the hypothyroidism. That means autoimmune cause, endemic goiter due to the deficiency of the iodides, then surgical removal of the thyroid gland, then destruction of gland by the irradiation. Now, if the hypothyroidism starts in the childhood, it is known as the cretinism, or if it is developed in the adult, it is known as the myxedema. First, we will take the cretinism in the childhood. Cretinism, the hypothyroidism during fetal life or infancy or early in the childhood. This hypothyroidism or cretinism may be due to the congenitally absence of the thyroid gland, or it may be the lack of iodine in the diet. It may be the congenital inability to produce thyroid hormone. Initially, there may be no symptom, but later on, movement of the neonate becomes sluggish. Then, very important thing that the skeletal growth may be more inhibited as compared to the soft tissue growth. Soft tissues become more enlarged, giving obese, stocky, and stout-statured appearance of the baby. Occasionally, the tongue is so enlarged that it obstructs swallowing. Now you can see the diagram over here, and then the condition of the myxedema. Actually, they are not concerned with the child. We have discussed the cretinism. There is a hypothyroidism in the child. And the top I have given the compare and contrast of both these things. While the myxedema is a case in adult in which slow physical and mental activity is there, the cold intolerance, and this patient is usually the overweight, lazy, low cardiac output, constipation, decreased sweating, cool, pale, thick skin. Actually, these patients having mixed edema, they have got more cholesterol level because this and due to this more cholesterol level, there is more chances of atherosclerosis and more chances of the cardiovascular diseases. So these patients usually dies earlier due to the atherosclerosis. So at the top you can see the difference between the cretinism and the myxedema. And the myxedema, you can see the diagram, the tongue become more enlarged as compared to the rest of the facial skeletal muscles, and this may create a difficulty in the swallowing. Now, how we can assess the thyroid function on the basis of different lab tests? The basic, you can see the backbone of the main test for the thyroid function test is the level of the thyroid stimulating hormone, TSH. You can see here, follow my cursor there, TSH. We usually, if the TSH is normal, T3, T4, they are normal, that means the person is normal. But if the T3 is low, then there are more chances that if the T3 they are low, then there are more chances that the T3 and T4 are high. Actually, level of the TSH usually moves opposite to the, usually, I am saying usually, not always, moves opposite to the level of the T3 and T4. If the TSH is low, that means T4 and T3 may be high. If it occurs, then this will lead to the hyperthyroidism. This is a main diagnostic. If it is low, then it will be high T4, high T3 high. Actually, these T3 and T4, they have got negative feedback effect on the secretion of the TSH. That's why they become low. Now, there are some other condition in which the TSH is low, but the other thing, the T4 and T3, they are normal. Again, we will take it as a hyperthyroidism. If it is low, again, and the first badge we have seen, first line we have seen, low, hyperthyroidism. Again, it is low, but the rest of things are normal. Again, we will call it as a hyperthyroidism, but this is known as a subclinical hyperthyroidism. That is hyperthyroidism showing no symptoms, subclinical hyperthyroidism. Again, if it is low and one of them, if T4 is normal, T3 is high, then we call it T3 toxicosis. If T4 is more and T3 is normal, then we call the thyroiditis or the different condition thyroidism in the early or the comorbid illness. Actually, these are different illnesses which may affect the thyroid. So, if the thyroid hormone, if the TSH level is low, then usually there is a hyperthyroidism. It may be a complete hyperthyroidism, it may be a subclinical hyperthyroidism, it may be a thyrotoxicosis, it may be due to thyroiditis, or it may be due to some other diseases. But if TSH is low, T4 is low, and T3 is low, all these things are low, it means there is a problem in the central nervous system. That means the TSH production is not there. If TSH is produced less from the pituitary gland, it will become low definitely. Then when its production is low, definitely it will stimulate the T4 TSH, T4 and T3, they will become low. So in this condition, when the TSH is low, the T4 is also low, that again T3 is low, then it will be called as central hypothyroidism. So this was all about the interpretation that on the basis of TSH. Now let's see another. When the TSH is high, when the TSH is high and the T4 and T3 they are normal. Actually, we should start from this line. If the TSH is from the second line, if TSH is high and T4 and T3 they are low, that is, this is the hypothyroidism, because they are moving opposite to each other. If it is high, they become low. This is the primary hypothyroidism. But if these two are normal and TSH is high, then this is known as subclinical hypothyroidism. Then if this will high, T4 is high and T3 is also high, that means TSH producing pituitary adenoma. So in this way, we can assess the thyroid function test or the function of the thyroid, and the rest of the things are also available. These things are that you can assess it with a fine needle aspiration, that is known as FNA from the thyroid gland. You can do the ultrasound of the thyroid gland. If you do the ultrasound, you can come to know the different problems in your thyroid gland. And finally, if you take the FNA, that is fine needle aspiration, that is biopsy from the thyroid gland, you can easily understand where is the problem. The next thing is, let's see, the next thing is different terminologies are used over here. What is meant by the hot nodule? Actually, the hot nodule produces excessive thyroid hormone. Let me enlarge this. Hot nodule. Hot nodule produces excessive thyroid hormone shown up on the scan because they take up more of the isotope than normally thyroid tissue does. These are almost non-cancerous. Actually, when we inject iodine isotopes of the different iodine, they are taken up by the different nodules. One of them is known as the hot nodule. That means it will take more iodine, and this is known as the hot nodule. Then we move to the cold nodule. They are not non-functioning. Hot nodule is hyper-functioning, excessive thyroid hormone production. Cold nodule is not non-functioning and appear as defects or holes in the scan. A few cold nodules are cancerous. 95% of the solitary thyroid nodules are benign. Only 5% of thyroid nodules are the malignant. Common benign thyroid nodules are the adenomas. Overgrowth of the normal thyroid tissue. This is adenomas. What are the adenomas? These are the overgrowth of the normal thyroid tissue. Thyroid cysts are also there, and Hashimoto thyroiditis may be there. The only test that can differentiate between benign and the cancerous is a biopsy. And here is the diagram of the cold nodule, warm nodule, hot nodule. Warm nodule is a normal production of thyroid hormone. You know the warm nodule. So this was all about the thyroid gland, how you assess the thyroid function, the abnormalities, hyperthyroidism, hypothyroidism, cretinism, and other things, and different lab tests we apply to discuss to diagnose the condition of the hyper or the hypothyroidism. So let's see. We will see in the next lecture, maybe this week. Thank you very much.